because there's a lot of clinical background research, basic science research, all the way to clinical studies on neuropathic pain, from basic science to clinical management. So it's quite a big topic. So I'm going to zoom in as much as I can into the latest evidence-based kind of guidelines. And this seems very interesting because as we go along with the guidelines, there's a lot more new things that we have seen. And of course, we follow a lot of ISP also in terms of definition. And the latest part of the thing about neuropathic pain is that there's ongoing research into what kinds of subtypes of chronic pain in terms of neuropathic mechanisms. And mechanisms-based kind of therapy is still being worked out because the medical science in terms of the types of medication, the types of intervention right now has not gone into the kind of mechanism-based therapy. So in terms of general therapy, we have a lot, but in terms of actual specific, for example, spinal cord injury, neuropathic pain, to even trigeminal neuralgia kind of neuropathic pain, we're still using quite a lot of old mechanisms. But it's interesting to know that there's a lot of understanding into this thing now. And certainly we look at kind of a definition in terms of primary, median, and peripheral versus the central nervous system. And of course, with the ISP looking at also the kind of direct consequence of a lesion or disease affecting the somatosensory system is what we're looking for. And the kind of mechanisms in neuropathic pain, mechanisms when we have peripheral to central nervous system, post-traumatic spinal cord injury, post-stroke injury, multiple sclerosis, there's a lot of kind of diagnoses that we see. And each one of them has got a slightly different mechanisms. And certainly when we look at clinical, we always look at scientific background, bench kind of work from the labs to the rats to the dogs, then to the humans, study translational science. We certainly want to also make sure that we can translate between basic science and clinical. And quite often, I think as practical physicians, we want to not just purely look at the basic science. We always ask, what can you do to use medications or treatment or interventions for our patients? And what about the kind of suffering, the kind of incidence of kind of chronic pain incidents? It's going to be a problem and challenge as well. And so in terms of neuropathic pain mechanisms, we know from diabetes to herpes zoster, to spinal cord injuries, to post-surgical pain conditions, we're seeing quite a lot of different kinds of mechanisms as well that is quite different and varied. And certainly when you look at the kind of specific background, baseline, benchmark kind of laboratory kind of mechanisms, you also see that there's a lot of peripheral to central mechanisms. So again, it's useful because when you see a patient, he's not just a patient with pain, he's a patient with complex mechanistic kind of pain. If you can differentiate not just nociceptive and neuropathic, you can then differentiate between peripheral and central mechanisms. You may or may not be able to treat all their pain, but you can at least explain to the patient that this is central mechanisms. This is real. This is happening at your brain level. This is happening at your spinal cord level. This is not just in your mind. And that's important because the patients quite often were told different things. They say, look, there's nothing wrong on your scan. So it's in your mind. You have to accept it. So when you give a wrong kind of message to the patient feels very wrong. They feel very defeated. They feel very misunderstood. And I think that's very sad for the patient, and that really gives them like a death sentence, there's no other treatment, you just live with it. And quite often we were still told by our patients coming in 2024, telling us that their doctors have told them they just have to live with it. And I told them, no, I refuse to accept that, because if you accept that, then that's the end of it. But if you don't accept it, you continue to explore possible biopsychosocial models. We have heard this morning. You continue to explore mechanistic treatment. You continue to understand about central sensitization and how potentially you can desensitize it. If something that is wired, something can be rewired. And quite often we may be too far in advance in our thinking, but we've seen, interestingly, a lot of cases that was told to be impossible. This is going to live with it. This is the end of the road. And the patient turned around. The patient actually has explanted a spinal cord stimulator not because of failure, but because of success. After 10 years of spinal cord stimulator, for example, the patient turned around and said, I didn't need to use it for the last 2 years, and guess what? I'm cured. I'm totally well from wheelchair, dystonic, and totally atrophic, and now I'm standing. And if you look at the pictures serially, you will be very amazed how the central nervous system can actually be rewired. And if you only can look at it towards the kind of treatment. Of course, I think we're still early days. There might be still more and more things that we can do. for these patients. And the pain pathway from the old textbooks on the dorsal horn, on the dorsal root ganglion, the A beta fibers and A delta fibers, as well as the C fibers interaction to explain allodynia, hyperalgesia, hypersensitivity, and all kinds of dorsal horn glial cells. We have a lot of mechanistic, pathways. Last time we talked about mu pathways from opioids. Now we're talking about cannabinoids pathways. We're talking about activation of different kinds of genetic factors, growth factors. They are all evolving. All right. So if you go to ISP meetings in the international conference, which I go on and off, I try to go about every 6 or 8 years so that I can get a bit of update. But it's interesting that the basic science research is quite a lot, but we still haven't got the translational science to our clinical practice. But certainly once you understand this, you will understand that there's so many mechanistic pathways that is worthwhile exploring. And that's why when you use a drug, when you think of what to use for your patient, you stop using celecoxib, you stop using toricoxib, for example, you stop using vitamin B12, you stop using vitamin C. I hope you can use if you have a reason for using, but I hope you need to understand that unless there is a scientific basis for B12 deficiency, unless there's a folate deficiency, one should be very selective in terms of dishing out multivitamins to patients, because honestly, they have a lot of tablets to take. They have a lot of tablets to take, and I don't think our job is to get more burden for the patient. First, do no harm. Our job is always to do good. If not, at least we don't do harm. So I think it's important to understand mechanisms. I think it's understanding the basic science, how the interaction of sodium receptors, calcium receptors, and how pregabalin, alpha-2 delta subunit of calcium receptors can be effective. But certainly one has to understand that from low threshold mechanoreceptor to NOCI pathway, we have a lot of reasons why touch becomes painful. And certainly there has been debunked on the crosstalk. There has been some scientific basis that crosstalk may or may not have happened. But certainly we see a lot of sensitization at the dorsal horn from zone 2 to increase to zone 5. And certainly we can certainly understand why they continue to have larger and larger areas of pain, developing into very complex regional pain syndrome if one does not even recognize that. Okay? I hope this is the latest slide that I've given last night, is to Dr. Kim, because I have got some very exciting research that has been evolved that was shown. But never mind, we'll go along and see. Okay, but NMPA receptors, as we know, is one of them. It's actually very interesting because we often use ketamine. IV ketamine has now been shown to even help patients with depression, and FDA has approved. And then we have used nasal ketamine, but we haven't got the kind of oral or even nasal ketamine at a correct dosage, FDA approved, that we can use for long term as an option for our patients, for example, without the burden of it being potentially central mimetic. And so certainly we want to find ways to actually break through in some of these pathways, and certainly these options. And the other options that we have to look at as well, besides all these subunits and receptors, is whether there's any kind of things that we can reduce the sensitization. And quite often when we see that the drugs couldn't do it, would the spinal cord stimulator inhibition pathway be enough to do? And we have seen quite a lot of cases when you use this kind of multimodal pathways, it's certainly very effective. And of course, not to forget the kind of ongoing support for anxiety, insomnia, depression, because those things also cause a lot of sensitization. And certainly if you go multimodal, multidisciplinary, multi-mechanistic, you can then become a pain physician to really look into breaking this code, which is extremely complex in most cases. So desensitization pathways continue to be a very challenging kind of interesting pathway. And certainly we see from spinal cord injury pain, for example, when patients' pain is impossible to be felt. There's no more feeling at the level of the transected cord. There is lots of sensation with a cross-section kind of dermatome where the patient cannot feel. But yet the patient can feel pain below and above pathways. And we know that this is due to, a lot of it is due to inhibitory neurons loss, inhibitory pathways damage, and certainly these are the kind of angle again you can enhance to help the patients to reset, if you like to call it reset, the central nervous system that has been damaged. And when you see damage, it's not just in the spinal cord. What about the brain? The brain has a lot of receptors that is ongoing, having a lot of rewiring as well. And certainly when you see that patients with cortical reorganization in central sensitization, and after 12 weeks of functional treatment, they can get a lot more areas back, rather than having it suppressed. And certainly patients have chronic pain, they have reduced cognition, they couldn't focus, they couldn't remember, they couldn't sleep, they couldn't even communicate very well. So they lost a lot of cognitive functional pathways in chronic pain. And in fact, a lot of studies on PET, MRI have confirmed the changes in the brain system. So certainly if you educate the patient this kind of scientific basis, you certainly want them to persevere with it, rather than just to give up, rather than just to let go, rather than just to lose their function day by day. And certainly by the time they come to you too late, or is wrongly treated with vitamins, wrongly treated with just surgeries after surgeries, certainly it's extremely complicated. It will be a very complicated case because the brain, the central nervous system, and everything else has gone wrong. So one has to treat early, try to diagnose correctly, and persevere with the correct directions, with the guidance of multidisciplinary kind of angles and inputs and agreements. I think that's how we can break through in difficult chronic pain. The disease is real. The chronic pain is a disease. We see it all the time. But what do you do with the disease is hopefully a cure sometimes. Hopefully at least to relieve all the time. So I think that's our job, all right? So end of the day, when patients receive medical treatment, sometimes they don't even receive treatment. And quite often, if they receive treatment, they can receive 4, 5, 6 different types of treatment. You can see in this chart, a lot of them receive 3 drugs, 5 drugs, 6 drugs, but if you look through, a lot of them are vitamins, or there are some very old drug, like somebody's given carbamazepine, for example, for lumbar radiculopathy. And that's wrong, because there's really no scientific basis to use carbamazepine except for trigeminal neuralgia. All right? Other types of neuropathic pain has not been shown to be effective, for example. And certainly one doesn't want to use NSAIDs or COX-6 because those are wrong drug again, using long-term for neuropathic mechanisms. There's no inflammatory mechanisms in these kind of patients. You really shouldn't use them because it causes harm, it causes no benefit. Again, our job as doctor, first do no harm. So the challenge continues for physicians, for patients, and there's a lot of comorbid conditions, and the treatment often is suboptimal. All right, so we do know about line 1 to line 2, and we also know that the number needed to treat and number needed to harm cannot be too close. That means you need to have the number needed to treat as small as possible. You want to have few patients you treat and you get a success. You want to have number needed to harm as high as possible so that more patients you treat before you can get one side effect. But quite often, a lot of these drugs, the number needed to treat and number needed to harm are quite close. So that's unfortunate because you have to titrate with time. So if you look at the kind of number needed to treat and harm kind of dosage mechanism, one also has to challenge the scientific evidence is that it's true, they have got very narrow band of use, but that means you need time to titrate. The patients need time to adapt to the effects and side effects. And quite often we see that the patients, after a week or 2, they don't feel drowsy, they don't feel unsteady. They actually find the drug helpful. So one has to start low, slow, but constantly titrating them. And what about opioids? Opioids is actually one of the options, but it's tough options, very challenging option. Especially in America, there are people with addiction, with dependency, who have died from it. All right? So one has to be very careful and selective, and it shouldn't be the first line or second line, it should be maybe the third line. Now, what about cannabinoids? Cannabinoids has been coming and going, and Chasi was sharing with me, Thailand now used to be the cannabinoid land, now it's going to be unlanded. So I think it's correct because when Singapore was asked whether we should have cannabinoids, I was the first one to be invited to in the ministry to give my opinion based on evidence base. We looked through all the evidence options, we say no, Singapore shall not bring in cannabinoids. It is not a choice of pain till we know much more. Maybe in very subset of patients, maybe in very intractable mechanisms, we may want to try, but those must be exception rather than the rule. So we have not allowed the drug to come in, and I think so far the decision has been correct. All right, the gabapentinoids, the pregabalin, the lamotrigine now stay still at the top part of the pathways. The choice of the rest of the anticonvulsant options remain less and less useful because of lack of evidence or more and more side effects that we know about, and there are better choices that's being used. But certainly when one is being pushed to second line, third line, fourth line kind of options, we can understand why. Because sometimes the first 3 drugs don't work, you need to go to the 4th, 5th, and 6th. You have to try to see whether the patients do rarely respond. when they don't respond to the rat fluid. I'm going to share with you some of the very older kind of guidelines. I hope that they have the latest guidelines that we did last night. And hopefully they can see that when we first sense the pain, we try with tricyclic antidepressants or small dose of SNRI. Now recently, the NHS, National Health Science from UK, as well as the body of evidence from international bodies of literature we have looked at, certainly even SNRI, one has to be very careful because even blood pressure can be a concern. So one must check the blood pressure as a baseline, and with time, if it does increase blood pressure, please take note. It could be from the SNRI, okay? It could be starting from the duloxetine, it can be acetylcholine, it can be any of your classes of SNRI. One has to be watchful for it. Tricyclic antidepressants is a very good choice of drug, but you have to then watch out for the elderly, for the tachycardics, for the patient with glaucoma. Otherwise, it's a very good drug, safe drug to combine or to use. Pregabalin is a good choice. Now, in the Nordic countries, in the northern part of Europe, there are start to show that there are more and more unusual behavior of addiction and dependency on high doses of pregabalin and gabapentinoids. We don't understand why, because most of these drugs really haven't much kind of euphoric or dysphoric kind of mechanism, but certainly if they combine with a lot of different drugs, they can get into a state of drowsiness and maybe a state of dependency with the use of pregabalin and gabapentin at high doses in the Nordic countries. That has been shown. And when it combined with opioids especially, one has to be careful. Once above 300 milligrams of pregabalin with opioid, one has to be very, very, very careful. Will the patient have dependency and tolerance effects, and also potentially addiction kind of profile is what 2024 we've now uncovered in some northern part of Europe in studies and follow-up. And of course, one has to also be careful with the use of these drugs during pregnancy. Pregabalin has been shown to have slight increase in pregnancy disorders for the baby in the first trimester. So in the past, we didn't know, right? So we said, no, there's no evidence for it. But now there's evidence to suggest that that could itself be a problem in causing certain kinds of problems. So I would say that no drug for this class. If you can, try to counsel extensively if the lady is pregnant or is going to get pregnant. I would be very careful to tell them that and document it. So these are the latest things that we have seen in the literature. In case the latest slide doesn't show up, at least I will tell you right now. As far as opioid goes, opioid is still a very evolving area. We see opioid epidemic in America. Patients die, patient dependency problems. But I always tell my patient and my colleagues, look, end of the day, it's not the drug alone, right? It's the wrong drug in the wrong hands of a doctor or the wrong hands of a patient that gets the drug wrong. And the drug itself really used carefully in select patients that you have identified carefully, you follow up closely, you're careful with the opioid consent or contract to agree with the patient on how to use, how not to use, how you control them, you reduce that risk. So that's a good doctor with the root drug on the right patient. And I think that's where it ends, right? So I don't think that the opioid itself is a bad drug per se. One has to be very balanced in the way they look at it. And the last thing is, of course, the quality of life. And looking at the objective is to reduce 30% of pain. In a lot of studies now, between 30%, maybe not even 50%, is enough to get a patient's quality of life improved. So I think that's important to understand. Sometimes you need to combine different classes. And when you combine different classes, especially when there's SNRI and there's a TCA, TCA is tricyclic antidepressants. One has to be very careful not to use the third one. For example, tramadol that can have serotonergic mechanism. They can then raise the risk of serotonergic crisis, where the blood pressures go up and the flushes go up. But certainly if you have 1 + 1 is reasonably safe. 2 + 1, you have to use a very low dose. With 2 + 1 plus another one, I would say no. I would say no, stop one of them since it's ineffective, and then you can switch to another mechanisms. Okay, so the slides have shown up. Now 2019 is a very interesting mechanism. Sorry, it's a very busy slide, but you can see the SNRI, tricyclic antidepressants, and gabapentinoids are all possibly useful, and certainly adding on tramadol, certainly adding on certain other therapies, interventional neuromodulation, even low-dose opioids is still currently within the 2020s guidelines for neuropathic pain. Not to forget the usefulness of a multidisciplinary team involving psychology, psychiatry. Sometimes the patient is so depressed, or sometimes patients have certain addictive profile. One has to involve an addiction medicine specialist because we cannot handle this ourselves. Some cases are just so complicated. In Singapore, we have patients who can show us, Americans or Chinese or whoever, they can come and show us, oh, I'm a teacher of international school, guess what, I'm traveling, I need to go and represent my class, I've got this boarding pass, I've got FDA letter. I can tell you, a lot of times you have to have a lot of doubt in this kind of patients, and you say, no, I'm not going to give you that long, you're going to go away for 3 months, I'm going to write a letter for you, I'm going to give you 1 week, you travel there, you see a doctor there, you come back, we can build a relationship, and it's a long-term relationship that tests out whether these patients are reliable. Quite often, if you trust the patient too much, you have too much compassion for them, you start to play their game. So a lot of patients can be very, very smart, very, very manipulative. They can even print out boarding pass for you, they can print out whatever employment pass we can have for you, they can have the FDA letter for you to tell you they are genuine. And I've caught them again and again, and thank God for Singapore, we have got national electronic medical records now. So we can key into their system, we can see that across the whole island, anyone else has given them the drug. If they have, and they told me that they have not, then there's an inconsistency. I'm going to just write it down, and I'm going to tell them you have been inconsistent, you cannot get the drug more than 3 days or 2 days. So we have a lot of patients coming to Singapore as a transit patient. They come in, and they say, oh look, I'm coming here, I didn't expect myself to stay so long, or my dog has just died, or whatever just died, whatever just passed on. And I say, yeah, maybe you can get another dog from Singapore. No, my dog I cannot replace, so I gotta get 2 months of medicine. I say, no, I can give you 2 days, and I need a letter from your doctor. So you see, that's a very challenging situation. The patients are in pain. We're supposed to show compassion. We're supposed to show love. We're supposed to